think I'm on. Can everybody hear me? So I'm Jeff Schelling from the Division of Nephrology, and I'm going to talk today about acute kidney injury, which is a fairly common problem in and outpatient setting, and so hopefully you'll find it relevant to the patient care that you provide. So I like to start out with this particular slide. It's not often that we demarcate dates by wars, but this shows a couple things. One is that there have been a couple finite periods of time where the mortality from acute kidney injury has changed, although we're pretty much stuck where we were in the era of the Korean War. And so one of the reasons this is demarcated by wars is that the improvement in mortality had to do with the medical care that can be provided in the field and being able to get patients to a place where they could be dialyzed. And then, of course, in the Vietnam War era, there were actually dialysis machines on Navy ships, and so I think that was a major breakthrough. But unfortunately, that was 50 years ago, and I'm not so sure that the mortality has changed all that significantly. And so I guess that's sort of a sore spot for us as nephrologists. All right, so when we get consulted by you guys or other services, often we're told, okay, this is a patient with an acute kidney injury, and usually your hunch is correct, but I mean that's really the first question that we have to ask is there really an acute component to this, or is this just progression of someone with chronic kidney disease? And while I don't have a slide up to show this, there's a pretty good literature which demonstrates that in patients that have underlying chronic kidney disease, they are at increased risk of developing acute kidney injury. So it's a relevant question. So how do we sort that out? Well, first of all, nothing replaces longitudinal data with GFRs, and I'll show you a subsequent slide where it's a little stylized, but how you can plot that out. And just as a preamble to that, often there'll be patients with some underlying diabetic kidney disease, which we know a fair amount about the progression of that disease. And the mean rate in a well-controlled patient with diabetes is about 5 mLs per minute per year, but the range can be tremendous depending upon whether there are other factors that are accelerating or decelerating the rate of progression. And so the idea would be you try to determine if somebody is really diverging from this rate of chronic progression. But many times we'll see patients where even you go into Care Everywhere and you just cannot find any other data points. You're stuck with what the patient is when they're admitted, and it may sort itself out eventually, but you really need to figure that out when the patient's in the hospital. And so I'm just proposing a few ancillary pieces of data which are not carved in stone, but if you see somebody with a normocytic normochromic anemia that could be from decreased erythropoietin production, that generally is only observed with chronic kidney disease. The half-life of a red cell is long enough that it's unusual to present with acute kidney injury in that type of anemia. Similarly, you can see patients with acute kidney injury who have hyperphosphatemia or secondary hyperparathyroidism, but that tends to occur more commonly with chronic kidney disease. And maybe the other thing I should have put on this slide is an ultrasound that shows evidence for fibrosis that would certainly lend itself to chronic kidney disease as well. And so those can give you some hints, but as I said, nothing replaces longitudinal data. And so this is just an example that I plotted out for you that which I think can be helpful. So let's say you've got a patient who has diabetic kidney disease, and so they're starting at the time they're diagnosed with a GFR of 125 mLs per minute. And it's another talk for another time, but many of the patients that are going to progress actually have hyperfiltration, so there can be this initial period where the GFR actually goes up. But for the point of this talk, we're going to say that they've got chronic progression at 5 mLs per minute per year. And you get consulted, or you have a patient on your service who at one point in time now has a GFR that corresponds, let's say, to this data point. Well, it's a little simplistic, but you can see that they've deviated from this linear progression, And if the graph looks something like this, you can be reasonably certain that there's an acute component that's superimposed upon that chronic kidney disease. And so then you can begin to think about a different differential diagnosis and not chalk it up just to chronic progression of this underlying disease. And then I also drew this line here. If you're taking great care of your patients and you realize that there's some intervention, and I recognize there aren't that many, that could slow the progression of kidney disease, it could look like this then, where you flatten the slope out, and if the patient's lucky, maybe it never intersects with the x-axis, they never have zero GFR, they never have to worry about needing dialysis. But the main point here was to identify this data point here, which would signify someone with acute kidney injury. All right, so I can quickly go through these next couple slides. I just want to make you aware that there are some staging criteria for acute kidney injury. This is called Rifle criteria, and then the next slide is called KDIGO criteria. And for the most part, this is not really caught on for the clinical care of patients. It's been used primarily to identify different classes of patients for studies. But both of these criteria, one criterion is GFR, and so you can see as you go from risk to injury to failure to loss of function to ESRD that the decline in GFR becomes more severe. And then there's a urine output criterion as well, and it also is more sustained and more severe with the progressive stages. And that's sort of similar. This KDIGO is a little more simplified. There's only 3 stages, but it's really not all that different, from the Rifle criteria. And I think maybe one of the reasons that this is not caught on so much clinically is that this is probably a bit overplayed, the amount of urine. I think we tend to care about whether patients are oliguric or non-oliguric, but we tend not to stage them based upon urine output, at least not on an hourly basis. And so, again, I just want you to be aware that there are staging systems, but you're probably not all that familiar with them. All right. So, a couple of themes I wanted to talk about. One is that we don't have great biomarkers to help us determine what type of acute kidney injury patients have, or even whether they've got kidney injury. And one of the problems is we're saddled with creatinine as a measure of GFR. And so, for the most part, you can think of the relationship between creatinine and GFR as being logarithmic, and so that really small changes in the creatinine in the normal range could represent large changes in GFR. And I think practically, what often happens is, you have someone, let's say, has a baseline creatinine of 0.8, and they present to you and it's 1 now. So is that significant or is that not significant? And I think most often what we do is, all right, well, let's repeat it. And the next one comes back, 1.2, but now you're 6 to 8 hours after that initial value, and potentially you've lost some time when you could have been intervening when this was a real case of acute kidney injury. And so that's a problem, that these small changes could represent big changes in GFR. There's also a kinetic problem in that the elevation in the creatinine lags the change in GFR. And so for a different reason, then we often get more than one creatinine measurement, so you can sort of see what the trend is. And once again, the horse may have left the barn by the time you've come to the conclusion that there really is a significant trend. And then finally, creatinine is just a poor man's marker for GFR, and it doesn't really tell you anything about what the etiology is, whether it's acute, chronic, or help you too much in terms of the differential diagnosis within those big categories. So creatinine's a problem. All right, so one of the things that I think you're probably going to see in the next few years is some point of care measurements of GFR. And I don't know how well this will catch on, but this is a publication from Bruce Molitoris, who's at Indiana, and he's been interested in being able to more accurately measure GFRs in real time. And so we've been doing this in animals for many years. And, so for example, in mice that we have in my lab, we give them fluorescently labeled inulin, which is handled purely by glomerular filtration, and look at the decay over time, and we can then calculate what the glomerular filtration rate is. And so surprisingly, this really hasn't happened in humans, and in essence, that's the premise behind Bruce's work here. And so they give two fluorescent molecules. Both of them are dextrans. So there's a large one with a large red fluorescent marker that sort of goes with plasma, so you get some idea what the blood flow looks like. But the more important one is a green fluorescent protein, PHTSI, which is coupled to a small dextran, which is exclusively filtered by the kidney. And so what they've done is, in this particular study, is they've taken patients where they measured GFRs by IL hexol clearance, which is the gold standard, but a little more cumbersome. It takes more time, there's a little more risk involved. And so that's their gold standard along the x-axis. And then they've taken their fluorescent decay-based methods and plotted the GFRs on the y-axis. And you can see that there's a pretty darn tight correlation here. And so this is now in phase 2B clinical trials, and I anticipate that either this particular assay or something like it will be clinically available in the next few years. And at least in my mind, I think acute kidney injury is in the ICU, for example, is an important place where you might want to do that, where you want to know what the GFR is right now and in this patient. Perhaps it could be helpful for drug dosing. There are all kinds of implications, but I think for getting a more accurate handle on acute kidney injury, this is going to be a real advance over creatinine. All right, so this is an old study now, which is sort of an introduction to beginning to come up with a differential diagnosis for acute kidney injury. And so I still think we think about patients as being in three categories, pre-renal, intrinsic or intrarenal, or I would argue tubular injury, and obstruction, so post-renal. And so this was a study that was done in an emergency department. They just took all comers there was a nephrologist who adjudicated what the type of kidney injury was, and you can see the distribution here. And then they just looked at several parameters like what was the baseline creatinine, how long was the acute kidney injury, and importantly, what was the mortality. And so, perhaps not surprisingly, in the patients who were deemed to have pre-renal azotemia, and most of whom had volume depletion, it was more quickly resolved, and the mortality was very small, only 6%. But that was in contrast to these other two groups where, admittedly, the N's aren't big, but the mortalities are significant. So those that had intrinsic kidney disease, which would be predominantly acute tubular necrosis and allergic interstitial nephritis, there's a huge mortality here, and not insignificant mortality in those that had obstruction. So, if you're in the emergency department or you're on the receiving end of a patient from the emergency department, if you're going to hedge your bets, most of the time they're going to have pre-renal azotemia. But obviously, you're going to want more data than that. But I think this just gives you a little bit of perspective. All right, so here is a more enhanced differential diagnosis that, again, sticks with these three groups. I won't dwell on this to any large extent, but mostly these are patients that are either volume depleted in the pre-renal category, or they have so-called effective arterial volume decreases. And so one way of thinking about it is they're on the other end of the spectrum of extracellular fluid volume. And so I think the easiest way to think about it is like somebody with heart failure, where they've got a bad pump and they can't fill the vascular space, and the kidneys perceive that as being volume depleted. Or a patient with cirrhosis who can have a tremendous cardiac output, but they're very vasodilated, and for a different reason, the kidneys perceive this as not receiving enough blood flow, and they'll behave similarly by holding on to salt and water. And then just don't forget that there are vascular causes that can cause constriction and diminish renal blood flow. And then I usually think about the next category, just obstruction, and this is probably a more detailed differential diagnosis than I often think about. But you just want to think that there can be intrarenal things within the ureter or the bladder, or things that can be compressing from the outside that can cause that. And then to me, the stickiest wicket becomes these intrarenal causes where it's a little more complex. And again, I would think of this as tubular causes. And mostly if you're going to distinguish with the fractional excretion of sodium, which I'll talk about, it's going to be high in this group, whereas patients with glomerular disease or vascular disease, things that precede the tubule, if they've got functioning tubules, they should have low fractional excretions of sodium. And so in this high fractional excretion of sodium, intrarenal, intrinsic, whatever you want to call it, in the hospital here, I think mostly we have patients with acute tubular necrosis and allergic interstitial nephritis. And admittedly, that can be from a number of different things: ischemia, medications, contrast, or rhabdomyolysis. And then allergic interstitial nephritis is almost entirely from medicines. There are some culprits that are more common than others, and I think it's incumbent upon you to go through the patient's entire MAR to determine if they could be on something that's nephrotoxic. And this allergic interstitial nephritis can be particularly problematic because it can be, for example, an antibiotic that's been stopped and it isn't even on the patient's current list and could be contributing to this. All right, so that's a differential diagnosis. And so there's some practical ways that you could help to sort this out, and I already alluded to the fractional excretion of sodium, which I'll talk about some on the next slide. But I think a practical test, and a reason why maybe as a nephrologist we don't see that many patients with pre-renal azotemia is that they already got bolused with fluid or treated for heart failure, and things got better, and they really didn't need our help to sort through this. But this slide is just a word of caution, if you will, about giving fluid. And the punchline here is that if someone has acute kidney injury and from acute tubular necrosis, for example, and they need to be started on dialysis, if volume overload is the indication that they do poorly compared to those patients that are not volume overloaded. So you can overdo it. And so I think because I'll go through the data here and then I'll list, tell you what I think the lesson is. And so this study, this Bouchard study, was patients who were admitted to the hospital who had acute kidney injury, and they made some distinction between those that were volume overloaded and those that weren't volume overloaded, and they defined that as a 10% increase in body weight over baseline. And so the upper graph shows what the outcomes were in fluid overloaded versus non-fluid overloaded patients at the time they started on dialysis, acute dialysis. And there was a significant difference between these two groups where the fluid overloaded group had a higher mortality. And then these are the patients just at the time of their acute kidney injury diagnosis who were not dialyzed. And this is also statistically significant, although barely. And then a different study, which comes to the same conclusion, is this is a randomized trial, and these are patients that had acute lung injury who were admitted to the ICU. So there were 1,000 patients, but 306 of them developed acute kidney injury according to the criteria that these investigators established. And so the purpose of this study was to randomize patients to either aggressive fluid management or conservative fluid management, and this was guided by CVPs and wedge pressures. And I don't remember the exact cutoffs for each two groups, but the patients were randomized to aggressive or liberal. And they came to the same conclusion here, is that those patients that were randomized to the liberal fluid group and developed acute kidney injury had a significantly increase in mortality. And the odds ratio at 60 days was 1.6 per liter per day in positive fluid balance, or another way is saying that is for every 100 milligrams of total dose of Lasix that they received in an effort to keep fluid volume down, that protected the patients by about 50%. And so I think the punchline here is, yeah, sure, if you have as objective evidence as possible that your patient is volume depleted, sure, you want to give them fluid, you want to do the right thing. But you can overdo it, and I think if you cause the patients to be fluid overloaded, you're not doing them a service, and it may be associated with an increase in mortality. So you just need to be a little bit judicious about it. All right, so I'm trying to combine both this concept of using fractional excretion of sodium and urea in this particular slide. It's a little embarrassing that this is probably the best biomarker we have currently to distinguish ATN from pre-renal azotemia, and hopefully I can convince you that there's some other biomarkers on the horizon. But this is, in my mind, one of the gold standards. And so the idea would be in patients with pre-renal azotemia that the tubules are functioning normally and they can reabsorb salt and water normally, and so they tend to have a low fractional excretion of sodium, as opposed to patients who have tubular injury, in this case acute tubular necrosis, where they cannot reabsorb sodium, they'll waste sodium, and the fractional excretion of sodium becomes high. And so that's shown in the yellow here. And so if you looked at the patients who had pre-renal azotemia, their mean fractional excretion of sodium was 0.4, and those with ATN, it was 9%. The problematic group, though, well, I can just go down here and say if you use 1% as the cutoff for the fractional excretion of sodium, almost everybody who had pre-renal azotemia fit that, into that category, whereas almost no one with acute tubular necrosis did. So it was a pretty good discriminator in this study. The problem, of course, is those patients that are on diuretics where you're hoping that they will waste sodium. And so, in fact, if you get a fractional excretion of sodium in a patient who's on a diuretic and it's low, at a minimum, it's not working very well. But most of the time, that's going to confound this interpretation. And so that's where this concept of fractional excretion of urea came about, where that's not influenced by the diuretic. And in this particular case, they use a cutoff of 35%. And so if you looked at everybody with pre-renal azotemia, almost everybody had a fractional excretion of urea less than 35%, and almost no one with acute tubular necrosis did. So, it wouldn't be wrong to just go ahead and get a fractional excretion of urea on everyone, but it probably mostly applies to those that are on diuretics to help sort out that as a source of volume depletion. All right, so there are a number of biomarkers that are being evaluated that I think are going to be an improvement, over fractional excretion of sodium, and probably the one that's the furthest along, although it still has taken a while, is called NGAL, which is neutrophil gelatinase-associated lipocalin. And, it's sort of an interesting story. It was discovered by two different groups in nephrology. There was one group that was doing animal studies of ischemic acute kidney injury, and they just did screen for an array of messenger RNAs that were up or down in response to that, and this was at the top of the list. But there was another group who was actually studying kidney development and knew a lot about this protein, which was critical for the development of tubules. And so they've sort of gotten together and published quite a bit on this particular marker. And so this was a study that was done at Columbia, where, again, these are patients that came in through their emergency department, where they determined, the cause of their acute kidney injury. And this specifically looks at acute tubular necrosis group. And so, they were screening with NGAL to distinguish that. They had a number of other markers. This is a brush border enzyme, as is this. They use creatinine, and they use fractional excretion of sodium. And so they looked at two different cutoffs of this NGAL, and you can see that the sensitivity and specificity is pretty darn good. That every diagnostic test would be this good would be great, whereas it was not nearly as good for any of these other biomarkers, including fractional excretion of sodium, which had an okay sensitivity but a really poor specificity. And I can tell you that many groups have now looked at this biomarker. Not all of them have such pristine data, but it holds up pretty well as a biomarker for ATN, and this is working its way through the FDA to be marketed. I think the next slide I've got a couple other biomarkers, and so there's this marker called KIM1, which stands for kidney injury molecule 1, which biologically has something to do with tubules sort of functioning as amateur phagocytes and reabsorbing things. But it's shed in injury to the tubules and is a pretty good biomarker. And in fact, it's the only FDA-approved biomarker for animal models of acute kidney injury, but not yet approved in humans. IL-18 has been proposed, this liver-type fatty acid binding protein. And then this combination here, this TIMP2 and insulin-like growth factor binding protein 7, is actually marketed. You can purchase this. It's called NephroCheck. And there was a study that was published in Kidney International where, again, this was just a shotgun approach, looking at the things that were most altered in the setting of acute kidney injury, and these were the two at the top of the list. And so these investigators, hurried to market this as a test. I think it's not caught on, all that well. I think it probably doesn't perform as well as in their original paper, and my guess is the best evidence it hasn't caught on is that many of you may not even be aware that this is on the market. But just so you know, that there is some progress being made on biomarkers beyond the fractional excretion of sodium. All right, so one of the things that I was really, as a renal fellow, it took me a long time to come to grips with this is, when we see patients in the hospital, the sickest ones tend to be those that have acute tubular necrosis. And so first of all, it's a pathologic name that's been applied to a clinical entity. If you biopsy these patients, they wouldn't necessarily have necrotic tubular epithelial cells. They wouldn't look healthy, but it's not necessarily necrosis in the strictest sense. But there is tubular injury, and most commonly it's ischemia that we see, although there are medications that are associated with this as well. And so if you did biopsy these patients, you would see tubules that don't look normal, but the glomeruli look completely normal. And so the question then is, why would injury to the tubule actually cause a decrease in glomerular filtration rate when those glomeruli look completely normal? And it goes back to the pathophysiology, and there are a couple different theories. I think the easiest one to understand is this obstruction theory, whereby when you've got injury to the proximal tubule, for example, many times the tubules will actually be sloughed and released from the basement membrane, and you can see those clinically as tubular epithelial cell casts in the urinalysis, but some of them don't make it out to the urine. They actually get stuck in the lumen and cause obstruction. And it can get to the point where you've got then equalization of pressure across Bowman space, and there's no filtration that occurs in that particular nephron. And so that's, again, I think the easiest explanation for me to understand how a tubular injury could actually lead to a decrease in glomerular filtration rate. But there's also this vascular theory where even in the absence of obstruction, if there's decreased filtration, through this nephron, that gets sensed at the distal nephron, and you can then get vasoconstriction here. And so it's called tubuloglomerular feedback. And so if you've got a way of thinking about it as a sick nephron, a sick tubule, there are signals that get sent, both biochemical as well as neurotransmitters, that signal back to that afferent arteriole. Don't filter through this nephron. This is a diseased tubule. Shunt that blood somewhere else. And these are not necessarily mutually exclusive theories, this obstruction and vasoconstriction theory, but it's just two ways of thinking about how you can get underlying tubular disease that manifests as a decreasing glomerular filtration rate. All right, so one of the things that was sort of a big debate in nephrology for a while, although this paper now is 10 years old, is when you see patients in the hospital, and particularly the really sick patients in the intensive care unit with acute tubular necrosis, it can take weeks, sometimes for them to regain renal function. And often we're supporting them with CVVH or intermittent dialysis or just watching daily until this creatinine normalizes or at least starts heading in the right direction. And the reason that takes so long is, fortunately, that the tubules can regenerate. So as opposed to some organs like the heart, where there's not a lot of remodeling that can occur, in the kidneys, they can make new tubular epithelial cells, but that takes time. And so I think this was sort of a clever study where they were trying to get at the mechanism of that. So for the longest time, it was thought that maybe there are stem cells that come from the outside, that invade the kidney and can repopulate it, and in fact, maybe that would be a treatment that you could give mesenchymal stem cells to enhance the recovery and accelerate the recovery in these patients. And so to address this, these investigators, Ben Humphreys is the first officer, who, by the way, was a Case medical student, they took mice and they labeled the tubules. And so they show it in blue here, but it's actually red in the study. And then they injured these mice by clamping off the renal arteries to create acute tubular necrosis, and then looked later to determine what the repair mechanism looked like. And so if there were cells coming from the outside, they would not have been labeled in red. So only the tubules at the beginning got labeled in red. So a cell from the outside, if it repaired, it will be interspersed with the resident red cells, as opposed to model number 2 is if there are progenitor cells in the kidney. When they divide, they would continue to express this red protein. And so, these are the data. These are the uninjured kidney over here, and you can see all the tubules fluoresce red. They then injured them with ischemia, and you have to take my word for it, but they all fluoresce red again. It was really black and white, or red and white in this case, where every single regenerated tubular epithelial cell still had the red marker. So it implies that regeneration comes from within. It doesn't necessarily mean that there may not be some benefit by giving stem cells, but it's not because they're actually replacing the tubular epithelial cells. If it's effective, it's because they're secreting things that may be helpful, that could enhance this endogenous regeneration. One of the things that I think has become popularized in the last, let's say, 10 years is this notion that we used to think that acute kidney injury was fairly benign in the sense that if you recovered, if you walked out of the hospital, everything was fine. And I think what we're recognizing now is that there's probably a significant percentage of patients who, even if they recover from their acute kidney injury episode, that they're left with some residual chronic kidney disease. And the problem is if you walk through a dialysis unit and you look at each patient, we don't know what the cause of their kidney disease is in most instances. But I think in many cases there's a contribution from prior acute kidney injury. And so this was an effort to model that, to determine whether that's correct. I mean, can you get acute kidney injury that's severe enough that it actually results in chronic kidney disease? And so this was sort of a clever way of doing this. These are mice that were engineered to express the diphtheria toxin receptor. And so mice don't usually express that. And so these guys made mice so that that was expressed in the tubular epithelial cells. And then they could give diphtheria toxin to these animals and kill the tubular epithelial cells selectively without harming the animal in any other way. And so what they saw is if you gave one slug of this diphtheria toxin, that's shown here, 1x diphtheria toxin, that eventually the GFR came back to normal, that the pathology went away, it was completely normal. But if you gave 3 doses over time, and so I think it's not hard to imagine that that could happen here in the hospital where someone has repeated episodes of ischemia, or they've got ischemia and then they get put on a drug that's nephrotoxic. That was a different story. These mice were left with some interstitial fibrosis. They even had some glomerulosclerosis, which again sort of gets at this tubuloglomerular feedback issue. And here you can see that the interstitial fibrosis that they observed was actually proportional to albuminuria, which is another measure of glomerular function. And I think that this is just a different stain. This is a Messon's trichrome stain. This is PAS here, and essentially so is the same thing. So, I think it's clever, maybe a little bit crude, that they gave, 3 episodes of this diphtheria toxin. Does this necessarily mimic what we see in humans? I think that that's debatable, but I thought it was sort of a landmark study that demonstrates that at least a form of acute kidney injury, when it happens repeatedly, can lead to chronic kidney disease. All right, so I alluded to this at the beginning that the mortality is high in patients in the hospital with acute tubular necrosis. It remains at about 50 to 70%, and there are some countervailing factors here. I mean, on the one hand, I think we're better at treating patients in the ICU. On the other hand, patients are living longer and they're sicker when they get to the ICU, so you sort of have those as opposing forces. But I would say that about 80 to 90% of the patients who are survivors will have complete functional recovery, and it's in this remaining 10 to 20% that they fall in this category akin to the last slide where they've got some chronic kidney disease. But some interesting things to note is that if a patient has acute tubular necrosis and they're on dialysis in the hospital and they're discharged on dialysis, say to an LTAC, 90% of those patients will not recover renal function. And then another sobering fact is if patients receive renal replacement therapy in the hospital for acute kidney injury, that there's a significant chance that that will be a repeated event over a 3-year period. So they're susceptible to more acute kidney injury. And so, the renal fellows write this in their consults all the time, and you probably get sick of seeing it, and maybe you just ignore it now. So, avoid nephrotoxic insults, meds, hypotension and volume depletion, and you want to say, of course, we will try to avoid those things. But I think that this is the reason they put that in there, is that these repeated episodes of things that happen in the hospital really portend poorly for these patients in the long term. So there is some literature to suggest that maybe the mortality is improving in patients with acute kidney injury, and this is a study that was published a while ago now out of UCSF, where they had like 5 million admissions to the Kaiser system. About 10% of those had acute kidney injury, and they demonstrated over time, that either in patients who required dialysis or who did not, that the mortality began to decline. And it's been debated and not easily reproduced. I think part of the problem here is that we're discharging patients, before we know whether they've got resolved acute kidney injury, let alone mortality, and sometimes on dialysis. And then there was a term that was used, DRG creep, where the coders, will put all kinds of stuff in the chart now that maybe we didn't include before. And so maybe acute kidney injury in 2002 was an increase in creatinine of 0.3, whereas no one considered that as a possibility in 1989. And I should have mentioned that this is all just chart abstracted data, for diagnosis. So this may or may not be true. I would still argue that a 25 to 30% mortality is incredibly high. So there are some predictive equations, for mortality with acute kidney injury, and these also have not caught on all that much. And I think a lot of these you would say, well, that's pretty obvious, but it's sort of an effort to come up with an Apache score for the kidney. And so in this one particular study that I'm showing you here, these are the odds ratios for the after a multivariate analysis, the significant risk factors. And some of them are, make good sense, on a ventilator, oliguric, had a heart attack or a stroke, of course. Sort of interesting here that bicarb was protective, although barely. And when these investigators then, took this formula, for predicting and applied it to another patient population, it tended to predict pretty well there too. And so this is increasing score as you go from top to bottom, and these are mortality rates in two different populations. And so, I suppose, we should think about this a little more often, particularly if you're having difficult ethical conversations, with families about, predicting outcome for their patients. If you've got a patient, with acute kidney injury and other comorbidities where the mortality is near 100%, perhaps this should be part of the conversation that we have with them. And you could think about, these sort of formulas to help with that prediction. That's just going to lead into another topic here, and this is sort of a justification for why we do continuous dialysis in patients, particularly, exclusively those in the intensive care unit. And that's this notion that renal blood flow autoregulation is lost in the setting of acute tubular necrosis. And so these are, I think, rat models where, the upper curve here represents, what normal autoregulation looks like. And so this is blood flow on the y-axis, and there are flow probes that are put across the renal arteries in these rats, and then they can adjust the perfusion pressure. And you can see over a broad range of pressures that the blood flow is maintained. And the only other organ, of course, that autoregulates like this is the brain. So the kidney and the brain have this capacity. But here, these are rats that were subjected to ischemic acute kidney injury by clamping off the aorta above the renal arteries. And these are rats that were given norepinephrine infusion. And you can see that the autoregulation is lost, and to the point where even what we would consider to be, in humans, the low normal range of blood pressures, there was a significant decrease in renal blood flow. And so one way of thinking about this is when we dialyze patients, maybe we should be thinking about the patients with end-stage renal disease where we push to get a dry weight and we put them in Trendelenburg and drive to get as low until they develop hypotension to establish these dry weights. Maybe we should be thinking about these patients with acute kidney injury a little bit differently, in that if you drive these blood pressures even into the low normal range, you might be diminishing renal blood flow, perhaps adding another ischemic insult to the kidney, or delaying the recovery by doing that. And so I think it's really this premise that led to the invention of CVVH, which we use pretty commonly in the ICU. And so when this first came out, people thought this was going to be a real panacea. It's gentler. We can remove solute in fluid over 24 hours. It'll be better tolerated, and it will result in better outcomes for the patients. And this is just one example where solute removal was examined, and so this is BUN here, and this is creatinine here, and you can see this is CVVH in the solid, and then the broken bars are intermittent dialysis, and so there is the capability of getting better solute removal with continuous therapies. But interestingly, in this paper, and maybe I was interested in this mostly just from a statistical point of view, is that they randomized patients to either intermittent dialysis or CVVH-DF or CRRT, I'm calling it here. So continuous veno-venous hemodiafiltration. So they had both replacement fluid and they were dialyzing against a dialysate. And so when they looked at mortality over time, there was a significant difference between the groups, but it was in favor of the intermittent hemodialysis. And this was a huge disappointment to the nephrology community. We thought we were doing the right thing, and yet maybe the mortality is actually greater. But it turned out, even though these were tremendous investigators and they went through great trouble to randomize these patients correctly, there were some poor prognostic factors that were overrepresented in the CRRT group, and so I think the data was a little bit biased. And when you then correct for these confounders, there's no statistically significant difference between the groups. And I think I've got a slide here which demonstrates. Well, I will have a slide that'll show it. It's sort of a meta-analysis of many different therapies. And so then there was a flurry of papers that came out both for intermittent dialysis and continuous dialysis, which initially indicated that if you gave a higher dose, and so longer dialysis, more frequent dialysis, more replacement fluid with the CVVH, that maybe the patients would do better. And so this was an initial study which demonstrated that as you go from, so this is survival on the y-axis, and these are increasing amounts of replacement fluid with CVVH, the mortality appeared to be better. And so people began to think, okay, maybe CVVH would benefit the patients, but we're not giving them a big enough dose of the treatment. And then around the same time, there was this paper that came out, small numbers of patients in the New England Journal of Medicine, which randomized patients to everyday dialysis or every other day dialysis. And similarly, there was a statistically significant improvement in mortality in those that got daily dialysis. And so, this would have really revolutionized the way we treat these patients if we gave them more intensive CVVH or intermittent dialysis. And both studies were a little bit flawed, and so there was an effort made to design the Cadillac of studies to try to address this. And so they randomized, patients to the nephrologist decided whether the patients were going to be on continuous or intermittent dialysis, and then they randomized them to either intensive or less intensive treatment. And this is what the mortality data looked like up to 60 days. These curves, intensive therapy in red and less intensive therapy in blue, were almost superimposable. And so I think we finally come around to realizing that these are supportive therapies. We're not really affecting the mortality in these patients. In general, there are so many other comorbidities associated with these patients who are on dialysis that those, of course, are coming into play as well. And so it's probably a little naive to think that our one treatment is really going to move the needle in terms of mortality. And I think that that's what's really been borne out with studies like this. And so this is a meta-analysis now that has looked at several studies, including the ones that I showed you in the last 3 slides. And so this is a forest plot where this represents unity. And so if there's no difference one way or the other between standard dialysis or intensive dialysis, you'd fall right on this line. And so, these are, a few studies that seem to favor intensive dialysis. Here's a few that favored standard dialysis. There was some effort made in these papers to score in this paper to score the contributing papers by quality. And it turned out that those that favored intensive dialysis were probably a lower quality study than those that didn't. But the bottom line literally is that this diamond here crosses unity, and while there may be a very small trend, towards favoring more intensive dialysis, it's not statistically significant. And so I still think we need to pay attention to whether we're giving adequate doses of dialysis to our patients, but going to every day or a higher dose of CVBH is probably not warranted. And then, finally, there's this notion, when do you start dialysis in patients with acute kidney injury? And there's been this debate forever about are there benefits to early start, getting on top of this and removing uremic toxins and fluid and preventing morbidity and mortality, perhaps, or do you wait till there's an acute indication, till somebody has, dangerously high hyperkalemia or metabolic acidosis, with the notion that maybe you're sparing some of the patients the procedure by waiting. And these are, two relatively recent studies that come to opposite conclusions. In this one, where they, randomized patients to early versus late, it appeared to make no difference. In this one, at 90 days, there was a difference in mortality. This one was just 60 days. At 60 days, these were not significantly different curves. And so I think the bottom line is that the jury's out. It's not entirely clear, the timing of when to do this. And, I guess it would be nicer if I presented you something a little more definitive, but I just wanted you to be aware that this is a debate that's still ongoing. And then here's a meta-analysis for this particular issue, and it's not too dissimilar for what I showed you in intensive versus less intensive dialysis. This is early versus late starts for acute dialysis, and again, the diamond crosses unity, implying that it's not clear that there is a difference. And so finally, I just was going to end with maybe gee whiz technology, what's on the horizon, and this is something that's probably not specifically going to be adopted, but there are cousins to this which may be. And so, when we dialyze patients, we put them on a dialyzer, which is shown here. I mean, there are these hollow fibers that are semi-permeable and allow dialysate to run in a countercurrent fashion so that we can remove poisons that, our bodies make, as well as extra fluid. It's a poor facsimile of a glomerulus, where we're providing a GFR of maybe, 20 mLs, per minute to a patient to prevent them from getting sick. But it really neglects the rest of the nephron, right? I mean, you've got these tubules that convert plasma to urine and do a lot of important things, secrete hormones, and there are a lot of important transport properties. And so this was an early effort to connect this crude glomerulus with this crude tubule. And so these are hollow fibers that are lined with tubular epithelial cells that presumably then would perform many of the tasks, in this case the proximal tubule. And these investigators thought, okay, if you hook these up in series, then this should behave a little more like a regular nephron. And they've got I'm showing you a little bit of functional data here where they call this a renal assist device, and they compared this to patients with acute kidney injury who were on continuous renal replacement therapy and saw, some difference in survival. I mean, this is not, really panned out. I mean, I think this has been a tough row to hoe for this particular group, and in fact, they started out, trying to market this for patients with end-stage renal disease. But, I mean, it does at least open up the conversation that there is a fairly intensive effort, mostly by people with engineering expertise, to develop wearable kidneys and to, try to make synthetic kidneys, that will perform the task better than a dialysis machine, and it'll be less cumbersome than a dialysis machine. Now, whether that necessarily changes things for your patients in the intensive care unit who are really sick, like a lot of the patients that I've alluded to, not entirely clear, but it may be, something that would be applicable in the time you're practicing medicine for patients who are ambulatory. So just to summarize, I mean, it's fairly simple. Bullet points I wanted to make sure I got across. I don't need to tell you, but acute kidney injury is very common in the inpatient setting. Anywhere, depends on how you define it, 5 to 10% of patients will suffer from this. Perhaps you didn't recognize that ATN is associated with an extremely high mortality on the order of about 50%, and I don't think we're any different here at Metro. It's a very high mortality. I'm confident that there are going to be some new predictive and perhaps mechanistic biomarkers that are going to come out soon that'll help us both with the diagnosis of different types of acute kidney injury, as well as perhaps help us understand the pathophysiology a little better. I just wanted to make sure that I showed you there, reminded you about that data, that it takes some time for tubules to regenerate by this intrinsic mechanism, and that's what you're waiting on when you know, your patients are stuck with elevated creatinines. And that unfortunately still the renal replacement therapies we have are purely supportive. They're not curative. And I think a lot of patients are hopeful when they go on dialysis that that means that we're curing their kidney disease, and unfortunately we have to tell them that we're just trying to do the job that their kidneys did, albeit not nearly as well. And I think the jury is still out in terms of whether there are going to be some engineering advances where, you know, these therapies really will be curative. So I'll stop here, and I'd be happy to try to entertain any questions you might have.